Okay, we're going to start on chapter 43, which starts on page 887. Pull up my two. Not what I was looking for. Chapter 43. There we go. All right. Hopefully we can get through this one a little quicker. My voice is starting to go out, so I'm giving it my best, but all right. So chapter 43, this is still in the central nervous system, just dealing with the spinal cord specifically. So keep that in mind as we're going through this. Primary concepts that we're going to look at are problems with immunity. And the example of that one is going to be multiple sclerosis or MS. We have problems with mobility for people that have spinal cord injuries from whatever cause, also known as SCIs. And then problems with sensory perception, especially in those with spinal cord injuries. Also related in this chapter would be problems with comfort, cognition or memory, and even problems with sexuality as well. Okay, so in regards to multiple sclerosis, this starts on page 888 and continues on for quite a while, actually. There's quite a bit covered all the way through page 894. There's a really good chart or table actually on page 889. Table 43-1 that talks a lot about multiple sclerosis or MS, which is a little bit easier to say. So I want to make sure that you take special care of looking at that and just kind of being able to differentiate, because there's another disease that we're going to talk about, ALS, also known as Lou Gehrig's, that kind of presents the same, but there are some stark differences there. So just make sure that you take a look at that one. But basically, this is a chronic autoimmune disorder. So we know that it originates within the body, that we're kind of born with, and it affects the myelin sheath and that ability for conduction in those pathways of the central nervous system, leading therefore basically to a disability for the patient. So what we see is this is usually in young adults, especially women. And it has usually a first line or a more familial type history of it. So if you have a first line family member with multiple sclerosis, then the chances are very likely that you would also inherit this as well. And I don't know if you guys learned this, but in regards to autoimmune disorders, if you have one autoimmune disorder, it's very likely that you could develop other ones as well. So kind of keep that in mind just for knowledge down the road. Okay. There are periods of remission and exacerbation. So if you look at the bottom of page 888, it talks about basically the 4 types or 4 different periods of remission and exacerbation that happen. But basically each time they're have an exacerbation, there's an inflammation process going on and the body is responding to it via these different classifications here. So we'll go over those here in a little bit more detail. Everybody progresses at a different rate, the same as any disorder. And typically what we see is it's over different lengths of time. So nothing very consistent with it, again, just as every other disorder. With the severity of the disease as it progresses, those periods of exacerbation become more intense and the periods of remission become much less. So really the focus at that point is just managing the long-term effects of it and again, preserving function for the patient as much as possible, kind of like we talked about with Parkinson's as well. So to talk about the different types, you'll see relapse remitting, primary progressive, secondary progressive, and then progressive relapsing. So again, this kind of all goes back to the periods of exacerbation versus periods of remission and how long those are lasting. So in a relapsing remitting course, this would be a mild to moderate symptom level, and it typically will resolve in a few weeks to months, and then the patient returns to a baseline, but they do have a baseline, okay? Whereas the primary progressive is kind of a steady and gradual change and kind of deterioration for that patient without remission of symptoms. So this continues steadily, and it has a progressive disability for these patients with no specific like attacks or exacerbations. It's just a progressive growth or change of this disorder, unfortunately, in a negative way for the patient. This is typically diagnosed at a later age, whereas some of these other ones we might see at a younger onset, kind of like when I talked about Selma Blair. She was very young when she was diagnosed. But this progressive or primary progressive is going to be diagnosed around 40 to 60 years of age. The secondary progressive is kind of relapse remitting course, but it becomes more progressive. So that relapsing remitting, remember, they have periods of remission, whereas the primary progressive does not. However, in this secondary progressive, we see where it continually gets a little worse every time they have an exacerbation, or maybe the remission doesn't last as long, and it just kind of progresses in that manner. And then the progressive relapsing is one where there's frequent relapses and very little recovery, but they don't ever return to that baseline. Okay, so maybe that will help as far as determining the differences there. All right, as far as assessment for and care for a patient with MS, if you again look at table 43-1, this kind of goes over some things that we are looking for. But it's really important that we have a baseline assessment on these guys so that when they come in and they are in periods of exacerbation, we know, you know, kind of how it's progressing for that patient specifically. There are signs and symptoms. So let's go over that. Basically, we're going to see some fatigue. We might see muscle spasms. Oftentimes these guys might be stiff in one area and spasmodic in the other area. Upper versus lower extremity, they might require a cane to ambulate or to get around. They might have paresthesias, definitely tremors, gait changes. So we want to kind of watch for that. And if you think about that, obviously there's some safety concerns there as well. So again, establishing a baseline, getting to know those patients, and then establishing your plan of care based off of that. They might have blurred or double vision. And if you watch the interview with Selma Blair, you'll see where a lot of years went by before she was able to get real help, because it's very hard to diagnose in such a young person. And these symptoms aren't necessarily normal for a typical young person. So it's very hard sometimes to get doctors to take these things serious. And it's very frustrating for patients who know that there's something not right going on, but unfortunately they're not getting the treatment that they need at an earlier stage. So I would encourage you to watch that, as well as the Michael J. Fox for the Parkinson's. They're very enlightening, and just seeing firsthand kind of how it's affected them, and you know, some of the emotions and stuff that they've gone through. It was very helpful for me, and hopefully it would help you kind of characterize that disorder as well. As far as care for this, there's really no specific diagnosis or single test that can help to diagnose MS. They can potentially do one of those electromyographies, which is the nerve conduction test, and that can help you determine if maybe there's a differential diagnosis as well. It can also help you distinguish between MS and the ALS that we're talking about as well. So with ALS, as you notice right next to it in table 43-1, it has a lot to do more with muscles specifically. So they might have weakness, they might have twitching, those kind of things, but you're going to see, you might see a little bit more of that on an EMG type diagnostic test. Other things that you want to watch for, they can do vision tests and things like that to see if there's anything going on with the eyes, but that's usually something that we see pretty early on is those vision changes for a patient with MS, okay? You might see those tremors specifically when they're performing activities. So it's not always beneficial to do something like an EMG because it might be activity induced, okay? As I mentioned, the symptoms are pretty vague and nonspecific, so you really want to look at the progression of any of these disorders, always establish a baseline and kind of help, you know, establish that plan of care in regards to that. All right, the other thing that we might see is fatigue, just again from all of that exaggerated movement, but fatigue in general is something that we do see for sure. So they're at a high risk for infection and decreased immunity secondary to that disease. Current therapies that we see are usually geared towards auto or like, you know, the immune system, specifically considering this is an autoimmune disorder. So anything that we can do to help with mobility, again, like I said, they might need ambulation aid. So you can kind of keep that in mind as well. And then at times there are definitely changes with visual acuity, but even cognition. So if there's an alteration in that central nervous system, it can eventually affect the brain as well. And so there might be some cognition involvement, okay? Chart 43-1 has some key features, kind of goes along with table 43-1, so you can look at that as well. A major thing that we would want to do here is to modify any effects that we can of the disease process, especially those affecting the immune system itself. Anything that you can do to prevent exacerbations, obviously we want to prolong the remission. Anything that we can do to help maintain or preserve their quality of life, so maintaining mobility for them, their function and independence as much as possible as well. The drug of choice, if you think about it, this is an autoimmune disorder with periods of exacerbation and inflammation. So the big thing that we would want to do is to try to help prevent or manage inflammation. So a lot of what we do with MS is actually corticosteroids, okay? One thing that I would want you to consider about, if this is an autoimmune disorder and we're giving them steroids, think about the alteration in immune system that they might have. So they're already altered, and then we add steroids on top of that. We know that lessens their immune response as well. So although we're helping them, we're also putting them in, you know, a little bit of a dangerous situation as well. So we want to make sure that we are educating them in regards to situations or things that they may want to avoid as well. Corticosteroids are definitely just for an acute period. It's not something that they live on lifelong. It's really only during those periods of exacerbation. So in regards to treatment and that, obviously the same as most other disorders, it does affect the whole family. So we want to do some patient education, things that we can help, you know, evaluate in the home life, safety concerns, anything like that, get them linked up with resources, support groups, respite care for anybody needing help as the caregiver, that, you know, alteration in roles. So someone that used to be a spouse is now a caregiver. That alteration can sometimes be stressful for families, or a parent, just in general, dealing with the effects of what's affecting their child. So just kind of keep that in mind as you approach taking care of patients with MS. I am going to kind of go back and touch on, before we move on to SCIs, I do want to touch on ALS a little bit. And I forgot to put this in the slides, but just so that you're kind of aware of it as well. This is also known as Lou Gehrig's disease, and it basically is an adult onset, so it's a little bit later. That's different than MS. So usually with MS, it's a little bit earlier onset. But there is an upper and a lower motor neuron disease, and it basically deals with progressive weakness, muscle wasting, spasticity, and eventually we see paralysis. There is no cure for Lou Gehrig's or ALS, and unfortunately what happens is with that paralysis, it affects every system of the body. So you're going to see where motility is changed, and like GI, GU is changed. They might need extra help in regards to that area. But more specifically, if you think about it, think about their respiratory system. So this actually progresses to where it can affect respiratory system, and they have a hard time breathing, clearing. They're at high risk for pneumonia. They might need to be suctioned. They might have a lot of secretions, those kind of things. But a lot of times when we see that they have progressed to that point, you're going to see where their death is basically attributed to respiratory failure. And so that paralysis, if you think about it, would be awful because it just progresses in an upward motion, and eventually it causes that respiratory demise. So I can't even for the life of me think about what that might feel like, because that is kind of like my biggest fear is suffocation. So I absolutely am empathetic towards anybody that might be experiencing this. If you look on that table, it does talk about characteristics of the disease. So definitely we have the fatigue. I told you more of the muscle atrophy and or weakness. And so they might do an EMG to kind of evaluate how much that has happened. You might see dysarthria, dysphagia, so difficulty writing, difficulty swallowing, clumsy gait or stiff gait, abnormal or spastic reflexes, things of that nature. So with the fatigue, with either of these disease processes, we want to limit their activity, especially in periods of exacerbation. Although we know with ALS, this is more of a progressive type. Either way, they both experience fatigue. And so things that we want to do is try to limit fatigue-inducing activities. We want to allow them to rest, times of rest. We want to make sure that environments are cool and not hot to where they would have to be working harder, or metabolic processes engaged. You don't want them in extreme temperature, so too hot or too cold, really, because heat would actually raise the body temperature to where they're kind of having to work harder, if you think about it, leading to more fatigue. So they might need frequent naps. There's so much to kind of think about this, but also you want to think about skin integrity. And then even as we go into spinal cord injuries, this is something major to think about, but they've got some atrophy, the paralyzation is happening, and so skin integrity is definitely going to be altered. So these are ones that we're going to be doing great skin checks on, and kind of helping them in that way as well. Making sure that bony prominences are padded, coccyx pad to help prevent that, making sure you're turning them, eliminating pressure points, those kind of things, preventing or kind of limiting how long they sit in a certain, like maybe even upright and things like that. So keep that in mind, and then just think about paralysis and how it's progressing upwards, how that's going to affect that patient as well. So we still want to be doing, any kind of exercise and mobility with them. Muscle wasting is very common with this disorder. We want to provide respiratory support, provide oxygen, maintain airway as much as possible. This is a person, though, if I think about some of these neurological disorders specifically, but this one more so, you want to make sure that you have it established as far as what they want to do if for some reason they do have respiratory compromise. Think further. So if I was getting this patient as an admission, I'm going to want to know their code status, okay? Because if you think about the quality of life for them, if they have progressed to the point where respiratory is compromised in this manner, they may not want extra things to happen for them. They may want, you know, to be able to allow, you know, natural death to happen. So just keep that in mind. Make sure that we address that, you know, on admission, and that you have that established with the patient and or family member as well. And then just follow, you know, if they had to be intubated, follow their wishes and the family's wishes. And if for whatever reason hospice needed to be involved, that you're providing support to that family as well, because this is, you know, kind of a terminal disease. Okay. All right, so we're going to move on to spinal cord injuries, which is on page 894. All right. Okay, so they are unfortunately caused by a hyper reflection and then even a hyperextension of the neck. So if you look at page 894, motor vehicle accidents are the leading causes of spinal cord injuries. And so there's an extreme flexion, so bending down towards their body, and then an extreme extension where it's kind of hyper extended as well. And so what happens are ligaments are torn, stretched, fractures might happen, but basically there's been, like it says on the screen, excessive head rotation beyond its intended range, okay? It could also be caused by penetration type injury, so specific traumas like bullet, like shotguns, or stab wounds, something like that as well, okay? No matter how it happens, you know, we see a loss of function that comes from that injury and from the spinal cord itself. So even though most of them are motor vehicle accidents, it really doesn't matter. Unfortunately, it's kind of life-altering for them. Any kind of non-traumatic ones would be something like maybe polio or tumors, bacterial or viral infections that when untreated, something of that nature. But what's going to result here is a loss of mobility and some paralysis. Along with that, they're going to have sensory perception loss. Reflexes are not going to be the same, and it's all going to be below the level of the injury, okay? It can be a partial or a full loss of bowel and bladder control and reflexes from the point of injury down, okay? So kind of think about that. Usually they're designated as either a complete or an incomplete spinal cord injury. So complete, the cord is completely severed. There's no chances of repair, total nerve loss below the level of the injury. They don't have tactile stimulation. They can't feel that, inability to move muscles, voluntary muscles. So they've got some paralysis there for sure, okay? An incomplete SCI would be the cord is partially severed and maybe there is still a little bit of function or movement below the level of injury. These are more common than the complete spinal cord injuries, okay? So something that we might do diagnostically, if you look, got some of these pages mixed up again. Give me 1 second. Okay, well, we're going to be doing CTs or MRIs basically to detect fractures, any dislocations, damage to the spinal cord, and then if there's any presence of bone or blood in the spinal cord or spinal column as well, okay? So the disability that you're going to see from this is basically tetraplegia, quadriplegia, quadriparesis, and that basically means, is there a complete or total loss of partial or all of, or like just a weakness of all four extremities, or if it's going to be a weakness and loss of function in just two, you know, lower extremities. Okay, so actually, if you look, I thought I had this page in here. Okay, guess I don't. Okay, so I showed it in the first slides in chapter 41 when we were talking about it, but just the level of its quadriplegia. C6 injury is going to be partial. The lower it goes, obviously, the more function they preserve. The higher the injury is, the more likely the paralysis to occur. Okay. Page 896 has these in a little bit more detail as well, but basically this is the disability that results. And like I said, the higher the injury, the higher the level of paralysis. So a good thing here would be to kind of establish a baseline again, just so that you know what their functioning level is and can determine anything that you need to do in regards to your plan of care. If it's something like spinal shock, if you guys look on page 896, that's something where maybe it's a temporary thing, but it's not a permanent thing, but they might still have an injury to that area. But what the difference obviously is that they are going to regain some of that function and a lot of that function back. This is just a temporary basis. That would be something specific to those spinal shock, and that is a temporary thing. Okay. Okay. Moving on. Things that we're going to assess and kind of establish for patients with spinal cord injuries. Always ABCs still. Okay. So you're going to focus on airway, especially if this is a new trauma. Making sure that you have that established, and you know, as they're coming into the ER and that, this is the very first thing that they're looking at, and then they can kind of follow subsequently in regards to that. So circulation, you know, are they bleeding? Anything in regards to that? Then after that, fractures. Obviously, if they're suspecting cervical fractures, they're going to stabilize that ahead of time. Prior to them coming to you, but you know, just kind of keeping that in mind as well. But when it comes to airway as opposed to fractures, airway is something that we're going to establish first. Level of consciousness, again, that Glasgow Coma scale, remember 3 is probably unconscious, well, not probably, it is unconscious and not good, whereas 15 is full neuro intact, so that's a good thing. Okay. Musculoskeletal, skin, all of these things, and then psychosocial. So if a person has had a spinal cord injury, obviously this is a very life-altering process for them, and there's likely going to be some psychosocial components that we want to establish. Skin integrity, again, these are things that we're going to have to think of for this patient and be mindful of as we're establishing their plan of care. Okay. Make sure you establish a baseline on these guys. Look for any signs of airway or respiratory problems, any nerve problems, any signs and symptoms of, you know, shock. So weak pulses, weak or tachycardic pulses, hypotension. That would likely let us know that maybe there's some internal bleeding as well. Okay, so keep an eye on those vital signs. You can check ABGs if there's some decreased oxygenation and increased carbon dioxide, then even low pH, then we know that there's likely some acidosis going on. Any of these things are very common with trauma and kind of what we're looking at overall. Obviously, in the after effect, once they've been stabilized, we want to consider things like pneumonia, any pulmonary embolisms because they're not up and moving around, any kind of clotting at any point in time, any fluid buildup. So keep that in mind. You might have some ineffective airway, impaired gas exchange, ineffective breathing. those kind of things. Definitely, we're going to have some impaired tissue perfusion. So again, we're doing skin checks. And then, like I said, that spinal shock, they might have a loss of movement initially, flaccid paralysis or hypotonia, but they typically will gain that function back. Usually resolves within 24 hours, but may last a couple of days to a couple of months, okay? Muscle spasticity can happen, especially in patients with shock, so keep that in mind as well. Usually when the spinal shock is resolved, then those spasms or that lack of reflexes and things like that will return to normal, okay? In regards to other assessments, for cardiac, we're looking for, like I said, the blood pressure issues, any kind of pulse issues, any cardiac dysrhythmias. So keep that in mind as well. If you think about their abdominal area, or where their level of injury is, obviously there's an increased risk for having problems with elimination. So you're going to want to consider that as well. They're going to be on, stool softeners and or laxatives. They might have their own, fecal promotion, or I don't really know how you guys bowel elimination program. So they're kind of known in different ways, but basically that we have that established because we know this isn't going to change for that patient. Likewise, the patient may have to self-cath, or they may have chronic Foley's too, depending on how severe it is for the patient and what their functional status is as well. All right. Kind of talked about those. Okay. So autonomic dysreflexia is on page 986. I'm sorry, 896. I put that in there wrong. And basically, what's happening here is an emergency type situation as a result of the stimulus or this emergency. So what you see here is spinal cord injuries, and they develop this emergent problem, but basically distended bladder or spasmodic bladder, constipation, any of these things could be a cause for it. But what will happen is they will have signs and symptoms above the level of the injury, okay? So they may not feel that they have a full bladder. They may not feel that they have a UTI or a pressure ulcer. But any of these stimuli can actually resort in this autonomic dysreflexia or lead to it, which becomes excessive, which leads to excessive sympathetic nervous system stimulation. So that fight or flight response or that stress response, which is definitely life-threatening, okay? So we treat it emergently to try to help prevent any kind of strokes or anything like that. But basically, if you look on page 896, there's stimulation that we're having a hard time getting control of. It might be tight clothes. It might be anything pressing, in an area that they can't feel, but they, we're not doing full assessments, so maybe we didn't notice it either. But this is something that you would want to watch for as well. They will likely have, they will have a change in vital signs. So if you look at chart 43-2, this is something that you might see. So diaphoresis, you might see some bradycardia, might change in the blood pressure, definitely. Any kind of sensations, like it's talking about goosebumps in this key features, but basically it's going to be in the levels of areas that they can feel, obviously not the ones that they're not able to determine. They might have blurred vision, spots in their visual field. And I will tell you, the most common procedure or thing causing this is a distended bladder, a kinked Foley catheter, or any kind of like tactile or painful stimulus. So a pressure ulcer, again, it's very important for us to be looking at skin integrity, especially if someone that might be quadriplegic or doesn't have sensation, even paraplegic, okay? Very, very important, especially in those lower extremities that they don't have feeling to, that we are doing good skin checks and making sure that we are monitoring output and things like that as well. All right, we kind of already talked about that. They can potentially do surgical treatment, depends on how severe the injury is. They can do a laminectomy, spinal fusion, rods, you know, those kind of things as well. One thing I forgot to mention, if you look further, autonomic dysreflexia, actually if you turn to page 898, it has a best practice or emergency care of a person experiencing autonomic dysreflexia. And so these are interventions that you're going to potentially have. And I'm not sure if I put that in there. No, okay. I do want you to look this over because there's, like I said, there's a reason why they're having this. And so we want to identify that reason. So if you notice that they've had this change in vital signs, and especially after they're stable, if you're noticing that there's a change in vital signs or, you know, like they're diaphoretic or, you know, just not presenting the same, maybe they've had a change from their baseline since they were stabilized, always look for things that could potentially be the problem. So look for injuries, skin integrity, look for kinks in any kind of a catheter. Look for any sharp stimulus or painful stimulus that might, you know, sometimes people when they're starting IVs or drawing labs or doing dressing changes, some of the stuff gets left in the bed, and it could be something as simple as that that causes pressure to that area that leads to autonomic dysreflexia. So make sure that you look for those kind of things and know what to do. So I would look that one over for sure. The other thing that I want you to know about is basically like on page 898 in that upper left-hand corner, you're going to see a cough assist. And this basically looks like as if they were choking or if you were doing CPR on a person that was sitting up. But depending on their level of paralysis, they're not going to be able to cough themselves. So they're going to have a hard time clearing any secretions. Hence the reason they're at an increased risk for pneumonia, okay? They can't turn, cough, deep breathe like we would encourage others. They may not be able to use the incentive spirometer the same. They may not be able to get a full breath, okay? So we're gonna wanna pay attention to lung sounds, whether they're diminished or any wheezing, things like that as far as pneumonia goes. But then they do have what's cough assist. Now this picture right now makes me cringe, especially with COVID going on, because I can just imagine having to do this with somebody and we're really already in a place where, you know, droplets are, you know, where everybody's wearing a mask, you know, we're in full gear, we've got the headgear and everything when we go in these rooms. So, but you know, COVID didn't change the fact that these guys might still need some assistance there. So just kind of keep that in mind. Protect yourself if you're doing this, just something to consider, okay? All right, so in regards to any other treatment for SCIs, you know, in the ER, for those of you that want to work in the ER, you might be setting up for intubation. You might be setting up for suction as far as, you know, they're at a risk for aspirating. You might be starting IVs. You might be starting fluids to try to help bring that volume up. Or you might be giving vasopressors to help with the blood pressure. If, you know, maybe the blood pressure is that low and fluids aren't doing it. So you might be giving vasopressors. You guys are going to learn about those. Any kind of supportive care, assessing for that shock, neurogenic shock, those kinds of things, okay? All right. So lumbosacral back pains, your lower back pain, and this starts on page 903. All right. So not much that we're going to go over with that because obviously you guys have probably a good idea of what low back pain is, but I want you guys to focus really on things that they can do to help prevent it. So if they have good posture, if they have a normal exercise routine, if you show them the proper lifting mechanics, lifting with their legs instead of, you know, bent over, practicing ergonomics as far as having things right in front of you, your feet resting on the floor, your desk and your chair at arm height, and those things, okay? So just kind of consider that, but that's really what I want you to look at in regards to low back pain. This is pretty common, usually non-surgical, and things that we would promote therapy or just changing mechanics for these guys, okay? Any kind of treatment for it is going to be more like anti-inflammatory, over-the-counter drug therapy. Although I will tell you that some people do progress to the narcotics, and so you know, unfortunately, then we kind of create some trouble there as well. So if there's anything that they can do, you know, weight loss, physical therapy, any of those kind of things, obviously we would promote that before we would put them on any kind of narcotic or long-term pain management of that. They do have, obviously you can do heat to try to help promote circulation to that area, provided they have sensation to that area. If you think about a spinal cord injury, this is very different than a person that has just low back pain. Spinal cord injury, you're not going to be using something like a heating pad because they can't tell you if it's too hot or if it might be burning the skin, okay? Low back pain is very different, and so just know that that's where we allow, you know, heat, ice, those kind of things. They have what's called phonophoresis, which is a topical drug like lidocaine and or steroids that they can use. And then they also have iontophoresis. And I know when I had surgery on my arm, they did things like this just to be able to provide just a little bit of relief while I was doing therapy. So keep that in mind. And again, therapy is usually a good thing to follow up with. They will likely send them home with home exercise programs. It's just a matter of compliance with the patients as well. Okay. That chart that I was wanting you to look at, or, you know, ways to prevent it, would be on page 904. Okay. If it progresses, they do have surgical management. It just depends on how severe it is. Again, those laminectomies, discectomies, where they're removing the problematic area, or they might even do a fusion between two discs as well. So they do have other things that they can do. These aren't as common, but obviously these definitely are not as common. Not something that I really see out there, but it doesn't mean that they don't happen. That might be something more pain management does, or neuro related might do these as well. With any procedure, obviously you're going to be checking to make sure that they're able to void, their vital signs are stable, neuro assessment is intact, any kind of pain control, wound care that they might have. Depending on where they have done the procedure, obviously we're going to check for any drainage that could potentially be cerebral spinal fluid. We're going to be working on positioning and ambulating for them. And then just setting them up for success in regards to home care as well. Any resources they might need, things of that nature. Okay. One thing that I do want you to know in regards to surgeries of this sort, if you look on page 907, there's a couple of things that I want you to take a look at. So I talked about looking for cerebrospinal fluid. So if you look in that safety priority, that's one thing that we want you to make sure. If they have any kind of bulging at that site, maybe it looks like fluid accumulation at that site, you want to let the doctors know immediately. If they have that headache, think about me being in the hospital on a caffeine drip, and, you know, again, not being taken seriously, or thinking maybe that my pain was unproportional to what I had going on. make sure that you're giving credit to those things and realize that that could be a risk for cerebral spinal fluid leak. So make sure that you're watching for those things and asking in regards to those things as well. The other thing that I want you to look at is in regards to complications that can happen as a result of lumbar spine surgery. So there can be, again, that cerebral spinal fluid leak. There could be fluid volume deficits. They could be retaining urine. So again, we're going to be making sure that they can void prior to discharging them. They may have a paralytic ileus. Okay, so abnormal opening or blockage there. They might have a fat embolism. So this is very similar, to blood clots. The only difference is that it's fat globules as opposed to anything in the blood specifically, or the blood clotting. So if you have a patient that after surgery develops increased or intense chest pain, any difficulty breathing, any kind of stridor, anything of that sort, or like a change in mental status, you definitely want to be assessing for fat embolism syndrome. And this is definitely an emergency. So the one thing that I would encourage you here, make sure that you get people in there and that they can help you. But you want to establish an airway, because a lot of times what happens is there's swelling there in regards to that fat globule, or basically that clot that we're seeing there. And as a result, it causes obstruction or swelling of the trachea and the airway. So please, please, please keep that in mind so that we can get an airway established, ASAP. Okay. The other thing too is with lumbar surgeries, if you look on page 908, sometimes they have orthotics that they have to wear, or a back brace or something of that nature that they have to wear prior to getting out of bed, or any ambulation or any movement. So make sure that you have a clear direction from the physician or the surgeon in regards to what they allow and what they would like to have happen, and be able to help the patients in regard to that as well. Okay. All right, cervical neck pain is on page 909, and kind of the same idea. You guys realize this is neck pain, and they can do procedures to try to help with that. So again, disectomies, and they can do fusions as well. So kind of combining two areas there. This is on page 909, but basically this is a result of problems with vertebrae. And so it might move out of place, or what we call herniate. It might be compressed, things on the nerve roots. So as you're looking at a patient like this, nerve pain tends to be very debilitating and hard to diagnose. So they might do a CT, they might do an MRI, they might do x-rays to be able to see if there's any compression. But they can also do a nerve conduction study to see if it's nerve related as well. Conservative treatment would again be therapy, making sure that it's stable. So if they need to wear a collar, they can do that as well. Making sure that they're on anti-inflammatories to reduce any kind of inflammation. But if conservative treatment isn't helping, then what we're going to see is that they're going to move to that more advanced or more invasive surgical options. If they do have to progress to the surgical management, obviously we want to monitor ABCs, because we're dealing, right near the trachea. So we want to make sure that we're assessing that. We're assessing any bleeding, drainage, vital signs, neuro checks, swallowing. Obviously these guys are NPO until we have assessed that. So we want to deal with I&Os, making sure that they're getting enough, after they have been deemed appropriate to drink and eat. One thing that I want you to know here, if you look on page 910 in that nursing safety priority as well, is that we're trying to maintain that airway. If you notice that a patient that's had a cervical neck procedure starts to have any kind of hoarseness in their voice, If they have stridor, respiratory distress, or anything like that, make sure you get somebody in there. Again, you've got to get an airway established, okay? And then notify the healthcare provider after that. But we have to establish that airway and then move to those. So kind of as I've been mentioning to you guys, make sure you establish what is most critical, what is most important, what is most relevant, and then move from there, okay? So as you approach these questions, and as you're looking at how to treat patients, always establish a baseline with them. Always establish what's most critical and most relevant, and then what are you going to do with that information? That's a lot of the questions that we're asking you. That's what your NCLEX is going to be like. So just be practicing those types of questions. And then hopefully, you know, when it comes time to test taking or NCLEX here shortly, you guys will be very prepared in regards to weeding out those, you know, yeah, I'm going to do that, but that's not the most relevant. Then get rid of it, okay? And just kind of move through them that way, all right? You always want to educate patients, and I know I don't always say this, but typically education for me is a big deal, and it's a big deal to anybody that has had any kind of disorder or disease process that this is new for them. So, you know, establish what they do know about it and what they do need to know about it. Education is huge for these patients. And as the nurse, that's going to be a big part of your job as well. Obviously, after they've been treated and are stable, okay? They might have lifting restrictions after a surgery, have someone drive them around, avoid strenuous activities, maybe have to wear a C-collar, those kind of things. Okay. All right. So I have gone over, everything that has been on the test. In fact, I looked over the test again, and I had seen it in the chapters as well. I will make sure that you guys have these posted tonight, and then you've got those focus points that I want you to kind of look at, but again, still making sure that you're reviewing the material as a whole as well, okay? I am going to post the videos of the interviews for Selma Blair with multiple sclerosis, and then Parkinson's with Michael J. Fox. And then I also have quite a few picmonics that are specific to neuro in general. Now, they may not all be relevant to just this part of neuro, but pick out the ones that are, and I would encourage you to watch those and see if maybe sometimes putting pictures to, you know, a disorder helps. Sometimes putting words to a disorder helps, or singing. So if that does, hopefully, you know, this that I post will help you, okay? So I will see you guys next week. Group 2 for, I almost said therapy, but it feels like therapy because we're going to get out. But for a clinical, and then see you guys on Tuesday for the test, and then those next 2 chapters, okay? Please let me know if you have any questions, and I am happy to help.